Hello, my name is Mari Beers. I'm a student of physical therapy at the University of Missouri, and today I'm going to be giving a presentation on moving away from using morphine as the primary treatment in neonatal abstinence syndrome and moving to a more non-pharmacological approach. So, women taking opioids while pregnant is the main cause of NAS, and morphine is most likely that treatment. So, a new way that we can start to combat using morphine is to move on to this new treatment that they call eat, sleep, and console. So, new evidence of this practice gives more emphasis on the non pharmacological interventions compared to the Finnegan neonatal abstinence scoring system, which can be very subjective compared to this new system. So, in the old Finnegan neonatal abstinence scoring, infants who were required morphine needed minimal PRN doses, and they would have already had a scheduled morphine. So, this new system is getting away from that. So, some amazing evidence that we've been seeing that using this new system of eat, sleep, console, which I'll talk about in a little bit, decrease the number of morphine doses from 38 per infant to 0.3 doses per infant, which is absolutely insane. So this new model, Eat, Sleep, Console, has been developed that focuses on the comfort and care of these infants by maximizing that non-pharmacological method and increasing family involvement, treatment of their infant, and when needed, the use of morphine. So we want to be able to have the infant eat at least 1 ounce or breastfeed as well, sleep for 1 hour undisturbed, and then be consoled within 20 minutes. So that's the main premise of this new system. So how does using this eat sleep model look? So the big thing is giving the family a sense of purpose within the hospital and the treatment of their child. So we want to um, be able to have caretakers or family there all the time or have volunteers when the caregivers are unavailable to help with the assistance of the treatment of this child who is recovering from NAS. So swaddling, positioning, quietly dim room, rooming in, skin-to-skin contact, breastfeeding, and infant positioning are some of the things that the research has been showing to have effect instead of using morphine as frequently. So you're thinking, what can I do? So how does PT play a role in this? So we want to once again focus on that family approach of having someone always with the child to have that skin-on-skin contact to ensure that the baby's getting all the love and support that it needs. We want to educate on the benefits of breastfeeding. So the American Academy of Pediatrics recommends that breastfeeding for infants with NAS because of the positive impact on the infant's GI, the bonding that it can bring, and then the severity of withdrawals and hospital stay can also be decreased. We also want to be doing an examination within the first 4 days. Everyone knows how important those exams can be within the first few days, especially with babies who have different impairments. So some things that we want to be aware of that are common for babies with NAS are that muscle tone, which can be assessed through examination because the fluctuations can be observed in various state cycles. These babies are also more at risk for developing torticollis due to a combination of factors because of their length of stay in the hospital and increased muscle tone in the upper extremities and neck. We also want to look at muscle flexibility. So it's important to do this when the baby is calm or in a drowsy state to get a true test. And abnormal movements, we can see withdrawal through 6 weeks of age and can vary based on the degree and the infant state organization. So some movement quality could appear rigid or ballistic during active withdrawal. So here is the benefits of this non-pharmacological treatment and what it can look like. So we want to do a general infant motor assessment, which pays special attention to motor quality, cervical and thoracic symmetry, cranial molding, locomotor milestones, hand-eye coordination, age-appropriate visual and tracking, and postural control. We want to use moderately to firm effleurage, followed by gentle passive stretching. And we want to educate the parents to perform these infant massages because it can reduce stress on the baby and depressive symptoms. So we want to be doing that for 10 to 30 minutes, followed by that stretching. Another thing that this evidence has found is the use of hydrotherapy. So a slow-paced handling during hydrotherapy should be used, and should also be educating the parents, caregiver, or volunteers on how to do it when they're there at the hospital. And then last but not least is developmental screening. So we want to be seeing these babies come in at 1 to 2 months after the discharge, and then when they're 4 to 6 months old, and then around a year, and then up until school age, so we can help prevent as many problems as possible. The long-term effects of this is still not quite known, but the more precautionary we do, the better we can help provide children the help that they need. Here are my references that I used, and I hope that we can go out and decrease the use of pharmaceuticals within our newborn babies and start using this new non-pharmaceutical approach.